All right, it is 12:30, so I'm going to get started. Welcome, everyone. My name is Peyton Messer-Smith, and I am the project coordinator for the Northwest Mental Health Technology Transfer Center. And we would like to welcome you to today's webinar on substance use, working with sexual and gender minority, or SGM, populations with Leah Post. And I'd like you all to take a second just to look at the important information section on this slide in case it answers any of your questions, namely that this webinar is being recorded. We will send the slides and recording to you at a later date. You will all get certificates of attendance emailed to you, and we are not able to offer CEUs for this webinar. All right, so a little bit about our network. The MHTTC network is a nationwide network supported by the Substance Abuse and Mental Health Services Administration, or SAMHSA. Our network includes 10 regional centers and a network coordinating office. And there are also networks for addiction and prevention using the same structure. The MHTTC network supports resource development and dissemination, training and technical assistance, and workforce development for the mental health field. And our Northwest MHTTC in the Fuchsia Circle covers HHS Region 10, including Alaska, Idaho, Oregon, and Washington. And now for a little bit more about our Northwest MHTTC. So this is a busy slide, but we have a few goals at our center. One is to accelerate the adoption and implementation of mental health related EBPs, heighten awareness, knowledge, and skills of the workforce, foster alliances and address training needs among diverse partners, and ensure the availability and delivery of free, publicly available training and technical assistance. And our area of focus is evidence-based practices for serious mental health issues such as psychosis. However, we provide training on a variety of topics, including integrated care, suicide prevention, diversity and equity issues, school mental health, peer support, trauma-informed approaches, and others. And our target workforce includes the behavioral health and primary care providers, schools, and social service staff, and others whose work has the potential to improve behavioral health outcomes. So how do we fulfill our mission? We provide free training and technical assistance, free self-paced online courses, live events like this webinar, and virtual learning communities. And we also provide things like weekly newsletters, our resource library, and other on-demand content on our website. So to find more about our goals, training opportunities, and resources, you can visit our website and sign up for a newsletter or follow us on social media. So just a few more notes for housekeeping. We will send a link to the webinar recording slides, as well as your certificate of attendance within 1 to 2 weeks. And during this webinar, we ask that you please use the chat for technical issues when you need our staff's help, or to share your general comments, greetings, or observations to everyone else. If you have any content-related questions for Leah, please put them in the Q&A box at any point during the presentation. We'll be monitoring the Q&A box to facilitate answering as many questions as possible at the end of the presentation. All right. Lastly, your feedback is crucial to our work, so we really do appreciate your response to a very short survey that'll take just a few minutes after the session. Our team will share that link in the chat today and by email tomorrow. We're required by SAMHSA to conduct the survey, but they don't have an official position on our content. And just again, if you'd like to connect with us, please just take a moment to scan the QR code on the screen or take note of our website, newsletter, social media, and all of that. Okay, and before I hand it off to Leah, I just want to mention a few of the events that we have coming up, and we will put a link to those in the chat. We have a webinar on de-escalation coming up on Wednesday, August 21st, and we also have a webinar on the mental health impacts of climate change coming up on Thursday, August 29th. All right, so with that, I would like to introduce Leah Post. Leah Post is a licensed clinical social worker, a Washington State approved clinical supervisor, and founder of Perfectly Queer Counseling. Leah graduated from the University of Minnesota with both a master's in social work and public health. Leah has spent their career providing support education and psychotherapy to folks ages 13 and up, and their focus is working with queer youth and adults. And Leah has built an all-queer practice of clinicians who bring lived experience and queer identities to their work. All right. Sorry for stumbling through some of that, Leah, but I'm very excited to welcome you and to pass things off. So I'm going to go ahead and share your slides. Just give me a moment.
Thank you. Yeah. Hello, everyone. It's great to be here with you all. Thanks so much for coming. Peyton did a great job of introducing, so we can start with the slides. I do have a little intro slide about myself as well, and then we can get started. So today we're going to talk about sexual and gender minority populations and substance use. I do want to have a disclaimer that I am not an SUDP, so I am not a substance use professional, meaning that I don't specifically treat substance use disorders. The goal of this is to really talk a little bit about how substance use can impact the sexual and gender minority community or the queer community. And this is a super, super broad, complex body of work. Substance use touches all different types of work. I am not going to go into like specifics about specific types of substances today. The goal is to really talk about the impacts on the sexual and gender minority community. And if you have any questions, again, please use the Q&A. I'll have it up on my screen. And so hopefully I'll be able to get to questions. Don't feel like you have to wait till the end. I want folks to get their questions answered. So the first thing I'd actually like to do on the next slide is find out a little bit about who's in the room. I know folks have been using the chat feature, which is great, but I'm always curious if, you know, what your licensure is, if you are a licensed professional, if you, what your title is, if you're not a licensed professional, or if you are. But if you could take just a moment to do the word cloud, and so that we can get a idea of who we've got sitting with us today. Ooh, this is a cool word cloud. I haven't seen this type before. I really like that. Awesome. Thank you, everyone. I'll give it a couple more, maybe 30 more seconds. It looks like we have an amazing group of folks in the room, lots of knowledge, lots of different types of work. That's really exciting to see. So thank you all for being here. And yeah, I'm just kind of looking at all the different folks. That's really great. Well, thank you all so much for being here. Thanks for taking a moment to share your work, share your title, share what brings you to the space. Let's jump in to some of the content. So a little bit about the learning objectives for today. So we are going to define what I'm going to be referring to as SGM populations and substance use today. We're going to identify some disparities for those populations, talk a little bit about the gaps in research, and there are a lot of gaps. We're also going to reframe resiliency. It can be easy to kind of go down the rabbit hole of how challenging this is, but also want to talk about all of the great things that are happening too for the queer community. And then also talk about local and national resources. I know that a lot of folks are from all over the country, which is great. I'm in Seattle, Washington, so my local resources will be for Seattle. And hopefully some of the national resources will feel helpful as well. I definitely don't have expertise in other areas necessarily, but want to make sure that folks at least have a few places to go at the end of the day. All right. So the definition that I am going to be kind of using today when talking about sexual and gender minority comes from the National Institutes of Health. I am going to read the slide. I won't read all of them, but I am going to read this one. So sexual and gender minority populations include, but are not limited to, individuals who identify as lesbian, gay, bisexual, asexual, transgender, two-spirit, queer, and or intersex. Individuals with same-sex or gender attractions or behaviors, and those with a difference in sex development are also included. These populations also encompass those who do not self-identify with one of these terms, but whose sexual orientation, gender identity, or expression, or reproductive development is characterized by non-binary constructs of sexual orientation, gender, and or sex. So I know that's a really big, big definition. Lots of words are in there. So if anyone has any questions about that, please let me know. Some of these things you may have heard of before, some you may not have heard of before, but hopefully we can dig in a little bit to it about what some of these things mean. So that's the definition of sexual and gender minority that we're going to go with. And then on the next slide, there are some caveats to that. So sexual and gender minority is not meant to be an umbrella term. So there are always going to be variations for how an individual identifies, how they want to identify themselves. And everything I'm talking about today is the research is done, and then folks often have to pick a category. We'll talk about that too. And so this is just the definition we're going with and is not representative of everyone. Also, a lot of the work that we're doing today is focused specifically on sexual and gender minority categories. And I want to acknowledge that there are so many intersecting identities that may come with that for a person, including race, ethnicity, socioeconomic status, immigration status, religion, etc. A lot of times the research doesn't always talk about or think about the intersectionality. Also, I apologize. My dog has a bone in the back, so I don't know if you can hear her, but it's keeping her busy. So that I just wanted to acknowledge and state that there are intersecting identities at play here. And when we're talking about sexual and gender minority categories or research or individuals, it is something that folks, oh my gosh, I'm so sorry. It is something that folks have a lot more going on in their lives than simply how they identify their sexual orientation or gender identity. So just wanted to put that out there and acknowledge that we aren't going to be able to talk about all of that today, but know that it is there. There are always going to be underlying intersecting identities. All right. So when thinking about defining substance use, so we are going to mostly talk about the DSM-5 definitions. And in some of the research that we'll see today, folks self-identify as having a substance use disorder, so that may or may not be something that was diagnosable. So sometimes folks will identify as having a substance use disorder that may or may not mean that they've seen a professional and received that diagnosis. So in talking about what the DSM-5 identifies, there are 10 separate classes of drugs that the DSM could contribute to a diagnosable disorder. I do say diagnosable with a little caveat because I also want to acknowledge and think it's important to recognize who the DSM-5 was written by and who it was written for. And it's not going to be written by or for all of the populations that we're seeing. And so I always have a little caveat when talking about the DSM-5. So these are the categories right now as it sits. There are also a number of substance-induced disorders that include psychotic, like substance-induced psychotic disorder or substance-induced delirium. So those are also included in these categories and are under like the anxiety category or whatever category they would normally fall under. not necessarily the substance use category. So there's a lot in the DSM-5 around substances. All right, so the next few slides that we're going to show, I'm going to start talking about disparities. A lot of these I definitely didn't want to reinvent the wheel. So I am using a number of visuals from other places. Some of these may be kind of fuzzy, so I apologize in advance. If anything isn't super clear, I'm happy to clarify for anyone who's interested. And again, recognizing that there are some limitations around the intersecting identities that may or may not be present in some of the following slides. All right, so we can get started. Generally, there are very obvious disparities when it comes to sexual and gender minority populations. Also, in all of these, it's important to notice who they're talking about. So in this top left, it says people who identify as gay or lesbian are more than twice as likely as those who identify as heterosexual to have a severe alcohol or tobacco use disorder. Notice that that doesn't include any other part of the rainbow alphabet. And what I mean by that is the LGBTQIA+. So this is gay or lesbian specifically, so more than twice as likely. I believe right now the statistic is that 5 to 10% of the United States population identifies somewhere within the sexual or gender minority population. And so thinking about what that means for these numbers. So 5 to 10% of the population currently identifies. So people who identify as bisexual are 3 times as likely to have a substance use disorder. We're also going to be kind of bouncing between youth and adults here. And so there's also that trans students were 2.5 more likely to use drugs than their cisgender peers. There are a lot of folks who aren't necessarily sure of where their identity is, and they're 5 times as likely to have substance use disorder than folks who identify as heterosexual. So in looking at these, there are a lot of things happening. There's a lot of different types of information on the slide like this. There's also some folks missing. There's also some pretty stark numbers. And unfortunately, they're only probably going to get more stark as we go in. So on to the next slide. So in kind of keeping in the same as the previous slide, LGBTQ plus adults are nearly twice as likely to experience a substance use disorder. 12% of the population 18 and older, so 12% of adults had co-occurring disorder, so a substance use disorder and mental illness. And we are going to talk about that as well, of co-occurring. 1.4 million LGBTQ adults have misused opioids. And 96% of the opioid users in the queer community misused a prescription medication. So they had a medication that was written, and then they misused it, meaning that they used it for something other than what it was prescribed, for pain or whatever that was. So this bottom one, 10% of total opioid users have used heroin. So what's interesting is heroin use in general has been trending down, at least in the Pacific Northwest. I don't want to speak to other parts of the country. So in the Pacific Northwest, it's trending down, and fentanyl use, and specifically fentanyl mixed with methamphetamine use, is skyrocketing. So this is from a couple of years ago, this slide. So I think it's from 2021. And so the other thing to recognize about all of this work is that things change really quickly. So while in this study, 10% of opioid users that identified with a queer identity had used heroin, I'd be curious now to see if that has shifted to maybe fentanyl and methamphetamines. So another thing to consider, that this is changing constantly. So this is looking a little bit more at mental health and also some intersectionality around homelessness or experiencing homelessness. The trans youth are almost four times more likely to experience depression. 1 in 3 queer adults experience mental illness. And again, these numbers are a little old. So this one is from 2015, and that's where we're going to talk about gaps in research. And I still believe that a lot of these hold up. 28% of queer youth said they felt depressed most or all of the time. So this statistic around the risk of experiencing homelessness. So queer youth and young adults have 120% higher risk. And thinking about, again, the intersectionality of what that might mean, why that risk is so much higher, and then also what survival looks like when experiencing homelessness. And then also 40% of trans adults have attempted suicide during their life. So the statistic is that the average life expectancy for a trans person in the United States hovers in the mid to late 30s right now. That's the average life expectancy. So it's something to really also consider when talking about substance use, when thinking about why these communities are using, what that means. And so there's just a lot that goes along with this. I did see a comment in the Q&A. So Leah, hello, love your name. For fentanyl use skyrocketing, is that people knowing they're using fentanyl, or could it include unknowingly using? Great question. It's both. So some folks absolutely know and are seeking out fentanyl use. And then there is, of course, a also high number of folks who don't know that fentanyl may be in the drug that they're using. And so it definitely could be both, but fentanyl is being sought out a lot more now by folks specifically. And the fentanyl is being cut with other things. So the fentanyl is being cut with meth and vice versa. So, but yes, people are both specifically seeking it out and having instances where they were unaware. And there are fentanyl test strips, and we will talk about some of those resources later too. But even the test strip just tells you that there's fentanyl. It doesn't tell you the level. So that's one of the big things, especially with accidental overdose, is the level of fentanyl present. All right, so this slide, I know it's a little hard to see, so I will read some of it for you. So this was asked specifically to the queer community about why folks are using. So what is it that might lead them to use? The highest percentage, so 38% of folks indicated, and this was for adults, indicated that they had feelings of loneliness and lack of intimacy or someone to confide in. So isolation seems to be a really big factor here. What's interesting is that 28% answered other, and at least in this visual, I don't have the information on what the other might be. 24%, or about a quarter, said that rejection or shame from family or friends. 17% said frustration from an inability to pursue a love interest. 13% said loss of employment or not receiving a promotion. 13% said isolation that arises from public ridicule and rejection. 13% is internalized homophobia or self-hatred. Another 13% discrimination or stigmatization based on their sexual orientation. About 10% said hate crimes, and about 6.5% said religious intolerance. So if you look at the do you or have you ever had problems with drug addiction, 32% answered yes. So that's a huge number. And going back to what I said at the very beginning, this is how the question was asked. So we don't know if this was a diagnosable substance use disorder, opioid use disorder. This is a the folks that answered this believed that they have had a problem with addiction. So these are all, things to think about if you are working with queer populations or sexual and gender minority populations. There's a lot that goes into why someone might turn to using or why someone might seek out substances. All right, so the next slide is a little confusing, but really interesting. So this was asked, if you look at the colors, it's the same survey as the previous slide, but this is the queer community's perception of who uses in their own community. So they asked folks, okay, what's your identity? And if someone said, I identify as a lesbian, then they said, who do you think uses the most in your community? So that's what this is. So on the left-hand side are the identities that folks have for themselves. And then the bar graph across is who they believe uses the most in the community. So what's really interesting is that the most folks believe that gay individuals use the most. And then second to that is transgender individuals. So these again are the perceptions of their own community on their community. What's interesting is that the questioning category, so folks who weren't in a place to identify for whatever reason, had a little bit more of a broad range. They also believed that other questioning folks were users. So this was just a really interesting thing because even within their own communities, there's still stigma or there's still assumptions made about who might be using or who they believe are the drug users in their own community. So I always really enjoy like showing this because I think it's really interesting to identify some of the internal biases that are occurring because that can also have an impact on substance use. So I hope that made sense. All right. So the next one, and this is going to be specific to King County. So the reason I wanted to show this is if you look at marijuana use, which in Washington State, marijuana use is legal. So, and it was legal in 2015 when this came out. And if we're looking at the folks who reported using and the LGB population, again, notice the T is missing, but the LGB population is the highest percentage at 39%. So 40% were using marijuana. Again, this is an older kind of number. There were not updated numbers on this, unfortunately, but I just thought that this was really interesting. And it does break it down by other categories. We also have age categories with 18 to 24 being the highest users. And then folks who identify as having multiple racial identities also being the highest users in those categories. So again, just kind of like looking at data in multiple ways to see where the impacts are coming from. All right, so this slide, I actually had the way that I set it up, I had them like all cool and layered on top of each other. But I will talk through what they are. So the one that you're seeing right now is again a 2015 study by SAMHSA. There is not newer data for sexual minority populations. And sexual minority is anyone who does not identify as heterosexual in their studies. So this is illicit drug use. And that is how the question was asked. Have you had illicit drug use? So however someone may identify with that, like if they feel they had illicit drug use, that's how this was answered. But I want to notice, like have folks notice some of these trends. In every age category, the sexual minority populations were higher, sometimes double or triple their heterosexual counterparts. So folks are identifying that they are using. Folks are identifying that their own, they believe they have illicit drug use. So there is definitely a lot happening in the community. All right, so for the next slide, I do want to talk a little bit about co-occurrence. I know I've touched on it briefly as well. So co-occurrence is anytime that a substance use and mental health disorder is existing within the same individual. So sexual minorities with a substance use disorder are more likely to have comorbidity or co-occurring disorders. So looking at this again, this little slide, so 7.7 million adults generally, so that is not specific to the queer population, but 7.7 million adults have co-occurring disorders in the United States. This doesn't always mean one caused the other. It's important to recognize that it's co-occurring for a reason. And also, and the reason I put these numbers over here is to show that this is something that is going on with a lot of folks. And so for adults with mental illness, 18%, and again, just adults, unknown sexual orientation or gender identity, 18% also had substance use disorders. So that's a huge number of folks. So there is research to show that gay and bisexual men and lesbian and bisexual women report greater odds of mental distress. And then also trans youth and adolescents have significantly higher levels of depression, suicidality, and self-harm. And a lot of that is, again, co-occurring with substance use. So it is definitely something super, super common. I know that in the mental health field, at least from my experiences, sometimes based on insurance or other reasons, we are talking about, sorry, I was reading the question, which I'll address in just one second. So when we are talking about co-occurrence, it's really important to recognize that that is something going on for a lot of folks. And in the mental health community, sometimes we silo ourselves, and that can happen because of insurance. It can happen because of resources. It can happen because of stigma. And so thinking about how to treat folks. So in the chat, thanks for the comment, Michael. It says, please start using culturally humble terms. Many LGBTQ plus people object to the term queer, just as a majority of Latin people object to the terms Latinx and Latina. Imposing those terms of other is faux wokeness. I appreciate that. I apologize if that is something that I have been doing. I will work on adjusting that as I go through the presentation. So for the next slide, so this one is really interesting. This talks about access to healthcare. So in this study in the past year, 1 in 4 LGBTQI plus individuals did not feel comfortable talking to a mental health professional about their sexual orientation, gender identity, or intersex variation. So the biggest thing I want to point out is, I don't know if the colors are able to be seen as easily for you all, but the kind of blue is LGBTQI plus. The purple is LGBTQI plus people of color. And transgender is sort of the green or teal. And so what's interesting on this is that there's definitely a cluster over here on the left of about 10 to 20% of folks feeling that they had some sort of negative experience with healthcare or with mental health professionals. And this very top one, so did not feel comfortable speaking to therapists about concerns related to sexual orientation, gender identity, or intersex variation. The transgender respondents were at about 50% or almost 50%. So that means half of the folks that responded to this survey who identified as transgender did not feel comfortable talking to a therapist or a mental health professional about their own identity. So I think that's really telling. I think it's really important for myself as a mental health professional to continue to learn and grow in what that means, how one can be more welcoming, how a clinic could be more welcoming. This specifically, I'm not sure if this was for a clinic setting or if this was for an individual private practice setting, but I just wanted to highlight that this is something that folks are experiencing, is discomfort within that same within what is supposed to be, or at least my goal would be that it's supposed to be safe for folks. All right, so another question. So has any studies looked at the use of drugs to cause desired changes for body dysmorphia? That is a great question. I have not found any when I've been looking, and later we'll talk about some areas that there's a lot of gaps in the research. And so I imagine that there are definitely folks who use substances to sort of have an escapism. If the slide a few slides ago about why folks within the LGBTQ community were identifying their own use, a lot of it was because they felt isolated or were just not feeling good about themselves. And so specifically around body dysmorphia, I have not seen that, but it is a great question and something I will definitely look for. So thank you for the question, though. I'm sorry I don't have a better response. All right. So looking at this is a 2020 study, so we're getting a little bit more modern here. I also want to point out that this study specifically was for folks with LGB identities. So this did not include folks with transgender identities. And that is a huge area of gaps in research, specifically SAMHSA. I've worked with a lot of SAMHSA grants. They're getting a little bit better, but there is a lack of options for even like having a trans identity. So, all right. So for on this slide, I know there's a lot going on. We're talking both about co-occurring again. So among LGB adults with a substance use disorder, and then among LGB adults with a mental illness, about 3.9 million or 23% have a co-occurring disorder. And so that is somewhat in line with the percentages of all adults in the country. It's slightly higher. So going back to the other slide, it was 18.2% of adults with mental illness that also had a co-occurring substance use disorder. So for the folks who were working or have an LGB identity, it is a higher percentage. All right. So I see a raised hand, but I don't know that we have the ability to do that. I'm not sure, Peyton, if you have a question, would love for folks to ask it in the Q&A, but I don't the great folks from the Technology Transfer Center can help direct that. Okay, apologies. I just wanted to make sure that got addressed. So again, this slide is just showing the rate of co-occurring disorders for folks. This does exclude folks with transgender identities. All right. Okay, so for the next slide, apologies for going into just a few King County, which is the Seattle County, but wanted to talk a little bit about what we're seeing in my neck of the woods up in the Pacific Northwest, and also looking at some of the trends. And I have seen a lot of these that have been extrapolated to nationwide. Also want to point out that at least this slide, when looking at the non-heterosexual identity, again, it's only the LGB. There is an exclusion of trans folks in this. And a lot of that is because of they didn't put the question. So, which we'll talk about in a minute. So the frequent mental distress question over here, this was from years 2011 to 2015. So in adults, looking at the age ranges by both age and income. And then there's also the binge drinking by sexual orientation and racial identity, race, ethnicity, and this is for 8th, 10th, and 12th grades. So thinking about what that looks like for young people as well. So if we're looking at sexual orientation and race slash ethnicity, again, the LGB identified individuals had sometimes 2 to 3 times higher percentages of reported binge drinking, specifically with their the Hispanic and Black community. So just wanted to let this one sit. Again, this is King County data, so Seattle, but something that is interesting to think about, especially when looking at those populations. All right, so kind of tying in with the comorbidity and co-occurring disorder. So percentage of adults with symptoms of anxiety disorder. So again, this is not a diagnosed anxiety disorder, but this is for the state of Washington. So again, if we're looking at the various, there's a lot of different ways that folks broke down the data here. So there is a sexual orientation where individuals were able to identify as straight, bisexual, gay or lesbian, or something else. There was an LGBT category, and then there was an LGBTQ plus category. So this is an interesting one because based on how someone might identify, the information changes slightly. So under the sexual orientation category, so symptoms of anxiety disorder, folks who identified as bisexual had the highest reported numbers. And then something else was the other option here. And so that was something that folks also identified. And then the LGBT and the LGBTQ plus categories were, from visually at least, very, very similar, if not exactly the same. And then I also want to highlight that the symptoms of anxiety disorder under race and ethnicity, there was multiple race or other race was the highest reported folks with anxiety disorder. So there's a lot of intersectionality and intersecting identities that are going on for folks. The other thing, just quickly wanted to point out under self-described gender on this form. So the transgender category had too few respondents to have a number. That's what that little up arrow is. And the none of these categories, so there was a female and a male and a none of these, that category was at the highest for self-described gender. All right, so for the next slide, this is sort of just a continuation of the last one, actually might be a repeat, so I apologize for that. But just wanted to highlight the sexual orientation, again, LGB with the T not being there, frequent mental distress, LGB adults reported the highest percentage of frequent mental distress. Sorry if that was a repeat. Okay, so I want to talk a little bit more about the research. I want to talk a little bit about why we're missing some categories, why some identities are simply left out, and then where it's going, where it's headed. So a lot of what you saw was in some of those, I would say maybe like half to 3/4 of some of the visuals that I showed were from federally funded surveys. So federally funded research is fantastic. It can come with a lot of money, but it also can be really challenging because it has restrictions and can often be quote unquote behind the times. So federally funded surveys only recently, and by recently, I mean like 2018, 2019, started to ask about sexual orientation and gender identity in their data. Prior to that, it wasn't even asked. They typically only had male or female under the gender category, and they did not ask about sexual orientation. Excuse me. So now what's showing up that they're asking those questions is they're finding that there's some disproportionate rates of substance misuse and or substance use disorders for folks that identify as not heterosexual. So we still don't quite have enough data to establish long-term trends. Trends can be a huge indicator for a lot of different things, but because we just haven't been asking the questions, we don't have even 10+ years of data for a lot of the populations that we're talking about. There are like pockets of the country within the United States, and I'm sure abroad as well. I don't have information about internationally, but there's individual states, counties, communities, cities that are conducting their local surveys that have included questions around sexual orientation and gender identity for many years. However, it's really challenging to extrapolate that data to the whole country, sometimes even the whole community that they're surveying, because surveys always have limitations, research always has limitations. So it's really important to kind of think about where the information is coming from, which is why I also try to give caveats to a lot of the data, knowing that there is a lot of missing information. The last bullet, so the quantitative health disparities research. So there is research specifically looking at health disparities amongst populations, and that's all types of populations. They're looking at disparities for religion, race, socioeconomic status, and those are still working on kind of getting up to speed and having enough data to feel long-term. And so they're still not really in a place where they have the comparison information where they can predict or accurately predict some of the health outcomes for folks within these communities. And so the research will always, well, not, I don't want to say that because I don't know the future, but the research will often struggle to be intersectional because of the complex nature of intersectionality. So if someone wants to study the impact of substance use disorder on the transgender community, for example, how are they also bringing in all of the different aspects of that person's life? So are they also going to be asking questions about where they grew up, where they're from, their family? Are they asking qualitative questions? If so, how is that being brought into the data? And so there's just a lot of challenges around intersectionality. I'm not saying that that should prevent anyone from doing that work, but it really, really needs to be something that's thought really mindfully about, because it can impact the way that people read the data or assess the data, or look at all of those fun visuals that I showed you today. All of those can be impacted by the work. So this is an example when I'm talking about we're not asking the right questions. This is an example of some United States federal surveys and how they ask the questions around sexual orientation and or gender identity. So these are, again, about 10 years old. Some are more than 10 years old. And this is how the questions are asked. And so for folks that are maybe questioning, for folks that are in a place where they don't like any of the options that are offered, then what happens? Is the data accurate? Is it skewed? You know, I do want to point out that under the second to the left, the NHIS 2014 question, they did have a something else option. And that was then met with an additional 6 questions that had, it's in the small print below. So I don't want to read all of it right now, but by quote unquote something else, they were then given 6 more options of what they or how they could answer that question. So there have been attempts made. There is still some work to be done. This information is slightly outdated, and a lot of the newer surveys still haven't necessarily caught up. So in my own work, I still work a lot with SAMHSA grants, and they're frequently given maybe 4 or 5 options. And as we know, the sexual and gender minority community can also really be a vast, broad, wide range of folks and identities and words. And the very first slide I showed about the definition of sexual and gender minority for today's purposes had, I don't even know, probably at least 10 or 15 different terms or words that individuals may use to talk about themselves or talk about their identity. So what's interesting, literally yesterday, and that's why I wanted to add this because this just came out. So SAMHSA just released its 2023 National Survey on Drug Use and Health. So this is all data from 2023 that they've packaged up and put together. What's interesting, again, in talking about intersectionality, so the three categories that they used for their data were race, ethnicity, and age group. So that leaves out a lot of different intersecting identities, including the LGBTQ plus population, including socioeconomic status, religion, immigration status, and the list goes on and on. So even this national organization from 2023 data, we're still limited in the information we have. And so I just wanted to show some key findings because I still think it is important to understand kind of nationally what is being found. So marijuana was the most commonly used illicit drug. I did not look specifically at what they identified as illicit drug since there continues to be more and more legalization of marijuana throughout the country, but that was still, marijuana was still the number one. American Indian or Alaska Native and multiracial people were more likely than most other racial or ethnic groups to have used substances or have had an SUD in the past year. Multiracial adults were more likely than other adults to have had any mental illness, serious mental illness, or serious thoughts of suicide. 12% of adults perceive they have ever had a substance use problem. So again, that's the same language around the difference between a diagnosis and a perception. So 12% perceive they've ever had a substance use problem. And among that 12%, 73% consider themselves to be in recovery or have recovered. And then for folks who were classified as needing treatment, age 12 or older, about 1 in 4 received it. So there is still a large gap of individuals who may be needing treatment and who are not receiving it. So this, the categories of the multiracial adults, it seems to still continue to be the similar trends that we've seen from previous, some of my previous slides around those categories, having folks that are disproportionately impacted or affected by mental illness, substance use disorder. So that that continues to seemingly be on the same page. But I just wanted to throw this in here. It just came out yesterday. So if you Google it, I'm sure it'll be top of the Google list. If you want it, it's a very long, very long outcomes list that they have, but it did just get released. So, all right. So I do want to talk about some places that are working to improve the research, who are creating avenues and funding streams specifically to look at sexual and gender minority populations, to look at the research, to fund the research. So the National Institutes of Health created a sexual and gender minority research office in 2015. And so it's been around. They are providing like funding to nationwide. They do funding. I saw some RFPs that they had on their site. I don't know if I saw any active ones, but so the work is happening. This is just one example of a national attempt to work on that. And again, I don't want to discount that local agencies, local jurisdictions, public health departments may also be doing great work around this. Just at a national level, it's still lacking. So this visual on the right-hand side is on the NIH's Sexual and Gender Minority Research Office main page about how they are approaching their work. And so they do have 4 goals. They want to advance the research. They want to expand the research of sexual and gender minority populations. They want to have a highly skilled and diverse workforce. And then they also want to encourage data collection in relation to sexual and gender minority populations. So the encouraging data collection piece, I think, goes back to a lot of what we've seen in the data that I showed today, that there are entire identities or groups missing from the information and from the data. So it's really important to think about what that means when you're applying to a grant, or if you apply for grants, or when you are considering setting up your intake paperwork. Like, all of those can be places where asking the right questions or asking appropriate questions can help increase maybe some comfort level for folks, or also help inform future data for the work that you're doing. So I do want to point out there is some national work being done, and it's still in the early stages. So the next slide is, I do want to talk about resiliency. So the sexual and gender minority population and community are very resilient individuals. There are so many ways, my entire presentation, in which we talk about, like, quote unquote bad, quote unquote negative, poor health outcomes, things that seem to be really, really challenging, and they are. So I don't want to discount the fact that things are really challenging. And there are folks that are thriving. There are members of the sexual and gender minority community that are living their best lives right now. There are so many folks that feel that they're in a better place than they were even a few years ago. Sorry, my brain just stopped working. The life expectancy numbers are going up for a number of members of the community, including the trans identified folks. And so there's just so many positive things happening. And so I want to highlight some of that before we wrap up today. So the 2022-23 data shows that approximately 70% of LGB, again, the T is left out, but LGB individuals do not have a substance use disorder. And a 2015 transgender health survey said that 70% of those respondents had never used illicit drugs. So there is a large percentage of these communities that are not using. Another thing to highlight is that many, many decades of HIV activism has created really, really strong foundations to set up the sexual and gender minority community for harm reduction approaches. So the great thing about that is that there's super, super solid work that has been done around HIV activism and harm reduction around HIV, and that has set up the community super well to talking about harm reduction when it comes to drug use. So that might be needle exchanges, that could be safe use spaces, that could be fentanyl strips, that could be Narcan distribution. So the great thing is that there is so much foundational work that has already been done that can be built upon. Also, there's so many great peer-led support groups in the LGBTQ plus community, and that can be locally, statewide, nationally. A lot of times, and folks find each other. People lean on each other for support, and those peer-led groups have a lot of power in being able to help keep people safe. So the other thing that's really interesting is that utilization of treatment in the data that we have, but utilization of substance use treatment is higher for LGBTQ plus populations than their heterosexual or cisgender counterparts. So when folks are experiencing a substance use disorder or feeling that they want to seek out treatment, they are doing it at a higher rate. So the other thing that's going on is, obviously there's a lot of struggle, there's a lot of negativity, There are so many oppressive and discriminatory policies coming out at the national level, state level, local levels, and folks are continuing to thrive. So I'm a member, I identify as queer, so I'm a member of the queer community, and seeing the beautiful spaces and the ways in which people come together is really wonderful, and also something that feels powerful. The last piece is there's going to be stigma. There's stigma around having an identity that's not heterosexual, that's not cisgender. There's stigma around drug use. There's stigma around people who have used drugs in the past and maybe are in recovery. And the visibility around sexual and gender minority representation is so important, whether it's in the media, in politics, movies, music. They have always been here. We have always been here. And so it's just that folks are feeling that they're able to be more visible now. And so all of that is really beautiful. So I just have two more slides, and they're both, obviously this is a joke, some light reading, but if you want to dig into any of this, here are some of the places that I got the data from. Also, on almost every slide, I did put the link to where I got that from. So hopefully that helps. And so there's a lot of data out there. There's also new data. I forgot to add the brand new, just released yesterday, SAMHSA data. But again, if you Google that, that'll pop right up. So, and then the final slide, again, local and national resources. So locally, thinking about Seattle and King County. So Peer Seattle is a great one. There is a Washington Recovery 24-hour helpline. We have a needle exchange. King County just launched a 24-hour telebupe hotline. So folks can call and get a buprenorphine prescription at any time from an emergency room doctor. It's fantastic. Currently just in King County, but we're looking at expanding it. And then there's harm reduction vending machines popping up all over the country. These are super cool if you haven't heard about them. So King County, I've seen them all over Wisconsin, New York, many places. So a lot of folks, these harm reduction vending machines have Narcan, and they're completely free. So they often have Narcan, fentanyl testing strips. They have, some of them have Plan B. A lot of them have condoms and other sexual health resources. So they're really cool, and they're popping up all over. And then nationally, there are some really great organizations, the Trevor Project, Gay Center in New York, Dance Safe, Recovery Connection. Friday Monday is actually a UK group, but they have great information on their website. And this is barely scratching the surface of the amazing resources available. So again, I just wanted to leave folks with some information, places to go, things to look at for ways that you can keep looking up this information. Again, this was not exhaustive by any means. This was just kind of to help us think about the ways in which this is impacting the community. So that is the end of my presentation. We still have some time left for questions. I am more than happy to answer those. And so if anyone has any questions, I'm here.
Thank you, Leah. I just wanted to hop on to, while we see if anyone has any questions, to thank you. I know it's really sobering, so I know I'm taking a deep breath and just thanking you for mentioning the parts about resiliency and the resources that are available. I think that's very helpful to include so we don't end on a very depressing note, because there is hope and that things are being improved all the time, especially with data collection, which you touched on. One thing I do want to mention, though, that stuck out to me was there was that one slide about how those who are unsure how to identify their sexual identity or don't have a specific label were 5 times as likely to have a substance use disorder. And that really stuck out to me, especially because I feel like questioning or maybe people with different labels are left out of the conversation a lot of the time. So So I was wondering if you have also seen that in the past or anything like that.
Yeah, that's a great question. And what's interesting is that so that 5 times as likely was also I don't have the exact numbers, but we saw that in some of the other visuals around when folks didn't feel that there was a box to check, quote unquote, that felt they identified with. And so it's not surprising, unfortunately. And in my own experience working with folks, I work with queer teen and adults, folks that identify in those ways. And a lot of young people, at least in my experience, say that if they don't have an identity, they do feel left out. And so sometimes they're like, oh, my friends all hold this, whatever the identity is, and I'm not sure yet. And so I'm othered. That's at least what I'm seeing with a lot of the young people I work with, some adults as well, especially adults who may have always presented, identified as heterosexual, and then come to a place in their life where that doesn't seem to fit anymore or feel like it fits anymore. Um, it's really hard for folks kind of within, I I don't want to call it a gray area. And a lot of folks call that a gray area. They're like, I don't fit anywhere, I don't have this identity. And the thing to remember is that these words were all created and we can create our own words, we can create our own terms. Folks can identify however it feels best for them. And the kind of like loneliness and isolation that folks can feel is really powerful. And that was kind of highlighted too, and why when asking the LGBTQ plus community why they use, that was something that they indicated as the number one thing was isolation. So it can be really powerful.
Yeah, absolutely. And I remember another bit that stuck out to me from that one that mentioned the isolation, the loneliness, was just how much, or how high of a percent, I think it was 28, was the other category, and how hard it is to capture, like you mentioned, like intersectionality, nuance in these types of surveys. And I know someone put in the chat, let me go up. Someone mentioned that they conducted a survey to understand the intersectionalities of disability and SOGI and income, and they found it difficult, even when trying to survey these communities to draw valid enough conclusions from the many sub-intersectionalities. So very challenging. Plus, this person mentions they didn't have too many participants, but the challenge I can imagine of trying to find this information even when you're directly looking for it.
Yeah, and when it comes to surveys too, a lot of people are rightfully a little bit sketched out sometimes if they're approached to do a survey. They're like, why? What do you want from me? Why do you want my data? Where is it going to go? How are you going to use this? A lot of folks have a rightful fear of it being weaponized against them. So there's just so many reasons why people may not even answer these questions. They may not feel safe to do so. They may not feel like they want to participate because they don't want to be othered. They don't want to be put in a place that would require them to out themselves, even if it's anonymous. I know a lot of folks have a lot of skepticism about anonymity and what anonymous actually means. So it's definitely challenging. It is hard to get participants, even when incentivized. And then if you're incentivizing, it creates this whole other level. And so, yes, it is very complex. And data is challenging. And I think I saw at least one person that was epidemiologist, and I don't envy that work because I love epis because I do not have that kind of brain. But also I can't imagine how challenging it is to kind of like try and gather what you have and then put it into some sort of report or some sort of fact sheet. So
Does not seem easy. And it seems like, I don't know if you see it, there is a question in the Q&A now, if you'd like to
oh,
tackle that.
yeah. Okay, so the question is, I've noticed that in my state, New Jersey, there aren't very many resources for LGBTQI youth and adults unless you have been labeled as disabled. Not many SUD treatment facilities that service our community. Funding is not as readily available as some politicians lead you to believe. Are there national agencies we can turn to for resources or funding? It's a great question. Very challenging. I'm so sorry that that is going on, and I'm sure you're not alone in that struggle. So for the resources, the Trevor Project is a great place to start. Highly recommend the Trevor Project. They are a national agency, and they kind of started as a texting calling suicide hotline, and then they've really expanded their services. So Trevor Project is fantastic. As far as funding, if you're looking for funding specifically for substance use treatment, SAMHSA, while plenty problematic, does still have quite a bit of funding available. So Substance Abuse and Mental Health Service Agency is what SAMHSA is. So if you have a nonprofit or a government agency, highly recommend checking out their listings. They do often have plenty of restrictions that come with it, but it may be a place to start. The other thing is working with local communities, seeing if there's other, especially for youth. I know that a lot of adults, LGBTQI plus adults, identify that they wish they would have had help too when they were young. So sometimes reaching out to the adults in the community and asking them how they would have liked to have seen those services, or if they have any ways to fund or finance any of that work. Unfortunately, you have to get super creative when it comes to funding, especially if you are saying we want to fund resources for sexual and gender minority youth. That can be very polarizing. So finding the allies in the community, whether that is an ally in a government official, like a school board member, whether it's a member of a local city board, I might not be using the right terms, I apologize. Whether it is a state senator, a state representative. So really thinking about where you can find that funding. And be creative about it. A little bit can also be helpful. So if there's mini grants that you can apply for, but Trevor Project is a great place to start.
Yes, definitely second that. And I actually see someone put in the chat, kind of asking the same question you answered right before, was talking about statistics shown and possibly missing some folks due to, maybe people not answering due to fear. So that is something that I'm seeing people also wonder, which goes back to kind of what we're talking about.
Yeah.
Yeah.
So yeah, I apologize. I don't know that I'm fully understanding the question.
I don't think it's a question, just a comment. Just
okay.
reiterating what we
Okay.
talked about before, where people might not be answering surveys or maybe have distrust based on kind of fears around what's done with that data and everything. So just kind of echoing, people were wondering. I think that was actually asked right as you were talking about it or right before. So
yeah,
it seems like it's on people's minds too.
Yeah. Kathy, I see your comment in the chat also. I can put my email. I'm happy to share my email if anyone would like. I can put my email in the chat and would be happy to talk with you further.
And I actually have one more question. If anyone else has any, put them in the Q&A. If you don't want to have us just chatting back and forth. But kind of, I'm curious if there, maybe about your experience, you talk a lot about surveys and the limited questions you can ask or the limited options you have. In your experience, has there been anything that you can do or anything that you have, any way you've approached it? Or is there really just kind of no option until these things change?
That's such a good question. Federally, when I've had SAMHSA grants in my work, you can't do much, unfortunately. We always try to give feedback. So when I have had grants in the past and we have to conduct surveys for our funding source, I always try to give feedback to our project officer or whoever will listen about, hey, yeah, we considered updating some of this language or looking at that. And I also know that there is so much that goes into creating a like quote unquote good survey question. So there's research about survey questions that's done. And so on a federal level, unfortunately, it's very challenging and requires many layers. Locally, if you have a small agency, if you want to get some information about maybe the populations you're serving, ask the questions that you want to ask. Also know that depending on how you ask, you're gonna get different responses. So yeah, if you work somewhere that you're like, you know what, we want to do a survey and you don't have to answer to anybody else, then go ahead and ask whatever you'd like. That's also something I think that's really important to point out is that, again, a lot of the information I showed was on a national level, so it's very limited. And I know there's so much great information being gathered at like more local levels. And so I don't have that information. I don't, outside of like where I'm at in King County, don't necessarily know where stuff is located, but you may know, not you, Peyton, but you all, you all may know where to find that. So I encourage you to ask your own questions. If you want to know, go ahead and ask. Folks may not want to answer, so just be aware of that. But it is something where if you have a community that you can build trust with and have a space that feels, welcoming, that may be a possibility for you to gather some of this information. Thanks, Peyton.
Yeah, of course. And I know it's nice to see that more. I mean, I'm thinking from personal knowledge, there's I think it's the 2022 US Trans Survey. I know that's a big one that's waiting for results to come out as they put things together. But it's so great to see that these gaps that you mentioned are starting to be explored. And obviously, it's not perfect because, think about surveys. I can think of bad ones very easily. It's hard to think of a good survey, honestly.
Yes.
So,
yeah. And so I'm from Minnesota originally, Minneapolis, and like Minneapolis has a great health survey that they do every year at Pride, and they've been doing it for years and years and years. That's a great one, but again, that's like local to Minneapolis and local to who's attending Pride and local to who wants to answer. So the work is definitely being done. It's just more how do you find it? Can that be extrapolated? I don't know. So.
right. Well, if people don't have questions, we can always end a bit early. Give me a moment. I'm just going to finagle with Zoom so I can put up the QR code for the evaluation survey and see if anyone puts anything in.
Absolutely. Thanks everyone for joining us. I appreciate all the great questions.
All right, I finally got it up. So if you scan this QR code, hard to talk today. If you scan it, it'll route you to our evaluation survey, which Gabriel also put in the chat. We really appreciate your feedback. We really do. We read it all, and I know our presenters really appreciate it too. So I just want to, put that up, and thank you again, Leah, for your expertise and for a really informative session. We will be sending out the recording with the slides to your email address. Zoom will send you a link to where we'll be posting it. But that'll be up within the next week or so, probably.
Great. Thank you all. I will jump off, and I really appreciate you all being here today.
Yeah, thank you, Leah.